not only we defined low engagement by someone having a detectable HIV RNA load, or they either had no HIV RNA data and had less than 2 primary care visits in the past year. So, as I mentioned in the cross-sectional survey, we ask additional questions, and for the purpose of this presentation, we focus on two specific questions. The first one you see here, basically assess responses of what would be the ideal to receive a long-acting medication. So you see the options here. And then the second question we ask is, what dosing interval would you like for your long-acting medication to be? And so going into the analysis, again, for the qualitative component, we gathered these data from the in-depth interviews. We basically identified themes. And for the purposes of this presentation, I'll focus on what was themed and coded as implant acceptability. And towards the end of this presentation, I'll share some perspectives that were given by patients about the implant. For the quantitative component, we ran chi-square proportions between variables of interest that I've listed here and their relationship with ideal long-acting ART formulation and ideal dosing interval. For our demographics, so we had 370 participants in our quantitative sample, and I've highlighted some key features here. So here we see a wide age range from 19 years old to 77, with a median age of 46. A large proportion were racial ethnic minorities, Latinx, and Black. About over a quarter were cis female. About a third were unstably housed or homeless. And then almost a half actually were fit a financial situation of struggling to survive or barely paying the bills. There was some rates of stimulant opiate use in the past 30 days, about 20%. And then also lastly, over a quarter were met the definition of being less well engaged. So now I'm gonna, the next several slides, I'm gonna go over our results and our findings from the responses of the questions that we asked. So to start, this was asking about ideal long-acting ART by modality, and this is overall. So here we can still see that the most popular option was still an oral pill long-acting form, and the least favorite was a subcutaneous implant. Now going into the next slides, we did find some statistical significance between some variables, and I'll go into that right now. So by age group, the three things that I really want to focus your attention toward here is if you look at the oral pill, there seems to be a bimodal distribution with younger folks 18 to 29 and then 50 years and older still favoring an oral pill option. The next thing I want to highlight is the subcutaneous implant I mentioned, that was the least favorite overall. But if you look at this between age groups, seems like young people are favoring that the most. And then the last thing I want to direct your attention towards here is looking at the transdermal patch. Those that are 50 years and older seem to like that the most compared to other age groups. And this is by clinic site. So UCSF and Emory look pretty similar. You still high interest in oral pills. The biggest difference was Chicago really interested in subcutaneous injection. And then this is by financial status. So the biggest difference that you'll see here again is in the one spectrum struggling to survive, intramuscular injection was most favored. Again, oral pill still seems to hold being the favorite among other financial status. And then as far as 1 year dosing interval, 1 year was the preferred interval for dosing. That would be really nice. So perspectives on implant as a long-acting ART modality. Again, this is from our qualitative sample where we looked at implant acceptability. Going to share just a few unique perspectives, but this was a patient who was concerned about not being going to clinic or seeing their provider and thought it would be more irresponsible with regards to their healthcare of having an implant. This person shared some safety and personal concerns. Really interesting that it might be a tracking device to monitor them. And then this last person, a 30-year-old guy from San Francisco, really embraced the benefits of an implant, sharing that it would remove barriers of a daily or monthly schedule and allow freer time to go to the clinic, see their provider maybe every 6 months or once a year. So very unique perspectives of disadvantages and advantages of an implant. So to conclude here, the findings overall, saw high interest in an oral long-acting formulation, low interest in an implant. We did see differences by age, clinic, and financial status on impact of the modality. There was a 1-year dosing interval that was the most favorite. And really, this was an exploratory analysis of modality and dosing interval within this patient population. Next steps that we should do are just perform statistical testing to see where the significance lies. And I think there's actually a good role for discrete choice experiments within these subgroups, especially to figure out how intersecting variables between dosing and modality might impact their preferences and attitudes. And then lastly, I think, we serve a diverse patient population here at Ward 86 and the other clinics. They have very unique perspectives and needs for long-acting ART. Our one size fits all approach to HIV treatment, it has been helpful for some patient populations, but not everyone, and especially the ones that we see here at Ward 86. And so I think as there's long-acting modalities that are being developed, we really need to understand their preferences so that we can better serve these patients. So lastly, I just want to give a big thanks, acknowledgments to all the clinic sites and the teams there at UCSF, Chicago, Emory, and then of course all the patients and our incredible staff at all the clinics, especially our beloved Ward 86. Thank you so much.
Takes time. Okay, great. I think, Jorge, thank you for that. That was a great overview of the work to date. And I think there's going to be a lot of questions as we go forward. There's at least one in the chat, but there's an eager hand up over here and one second level, 3. All right, we probably have time for 1.5 questions. So Monica, you were technically first with your hand up, but you can defer.
Well, I understand at some level the point of this type of research, except that there is no once yearly ART, and there is not a formulation that's out there, even in imagination, that would be that. So I wonder now that we have long acting and then we have the 6-month, if research will be honed to be concomitant with the realities of what's going to be available.
Yeah, I think it's really challenging. Like I agree. To make a oral pill to last a year, like I don't know if we're ever gonna have that technology. Maybe one day, who knows? But at least sampling the specific groups to see what they would like. Once these things are being rolled out commercially, I think we can sort of prioritize where we should focus these interventions towards. Obviously, they're going to be studied in overall general population so that we can know like safety and efficacy. But once they're rolled out in the real world, then we can know how to divert our focus and priorities to which groups. So
rapid fire, Matt, and then Peter, and then.
Thanks so much for that really interesting presentation. I'm curious if you've looked yet at stratified by housing status and if there are things we can learn for our unstably housed populations from your analysis. Thanks.
Yeah. We our analysis was pretty broad. We did also look by housing status. From the initial analysis that we performed, there wasn't anything that lit up with statistical significance, but definitely something to look into other populations as well.
And just a quick comment on the implant that really resonates. What you found in that with people with psychosis, a very common delusion relates to things being implanted inside you. You can imagine people with mental illness.
Right.
A lot of the people were trying to help with longer acting therapies. It may present some challenges in terms of communication on implants.
Yeah, definitely. I think I didn't look at the full history on that patient, but it would be interesting to see if there was some psych history back in there too. Yeah.
All right. Thank you so much. I'm trying to clap, but I have microphones in my hand and everyone's clapping online. So now we will move on to the next phase, which is also you talking.
All right.
So, use that one if you want.
Yeah, I'll use this. All right. So I have the honor of introducing our guest speaker, Dr. Duncan. So Dr. Dustin Duncan is an associate professor in the Department of Epidemiology at Columbia University School of Public Health, where he directs Columbia's Spatial Epidemiology Lab and co-directs the department's Social and Spatial Epidemiology Unit. He's internationally recognized social and spatial epidemiologist, and his research broadly seeks to understand how social and contextual factors, especially neighborhood characteristics, influence population health. His intersectional research focuses on Black, cisgender, gay, bisexual, and other sexual minority men and transgender women of color. His work appears in leading public health, epidemiology, medical, geography, criminology, demography, and psychology journals. He works in collaboration with scholars across the world and has over 200 high impact articles. And his research has appeared in major media outlets, including US News World Report, Washington Post, New York Times, and CNN. His recent work has been funded by the NIH, CDC, and HIV Prevention Trials Network, as well as the Robert Wood Johnson Foundation. He has received several early career and distinguished scientific contribution, mentoring, and leadership awards, including from the National Academy of Medicine, the Harvard University School of Public Health, and the Interdisciplinary Association of Public Health Science. So without further ado, let's give Dustin Duncan the honor of giving his talk.
Thank you for that very generous introduction. So I'm excited today to talk about multi-level risk factors for HIV prevention and care among Black sexual minority men. I'm fortunate to be the PI of two cohort studies, one called N2, which I'll talk about today, which is mainly focused on Black cisgender sexual minority men, but also I'm the PI of a study called TURNT. So not in this talk, but you'll see some of our forthcoming work. That's a cohort of about over 314 trans women of color in New York City. And I'm really excited that we have about an 83% retention rate in that study so far. So first I'll talk about Black sexual minority men and HIV disparities. Then I'll talk about this multi-level perspective to HIV prevention and care overall. I really spend the time talking about our study, our design, our results, and I skimmed some of the future research, so happy to engage there. But I'm going to talk about some of the future research, things that I have in my head, and some of the kind of the grants that we have in review. So this is a stuff we talk about a lot. I'm sure you and CAPS and the CFAR talk about, but Black sexual minority men and HIV disparities. So this article came out in the New York Times in about June, I think, of 2017. And friends and colleagues were texting me and emailing me like, oh, did you see this? Did you see this? And it really talks about what we already know. We know that HIV remains a public health problem and issue, especially among Black sexual minority men, and especially in the Southern United States. So this is just shows that just worldwide, HIV remains a problem. For example, globally, gay men and other sexual minority men are 27 times more likely to be at risk for HIV than the general population. And I really like this this figure because it shows HIV around the world, but across different particular continents and countries, and we see that that disparity essentially exists ubiquitously. And just here in the United States, again, we see that HIV is really isolated in sexual minority men. So here's the thing: we know that there's heterogeneity in HIV, everything: prevention, acquisition, treatment, care, behaviors, et cetera. And so we see here that the incidence of HIV has been declining overall, but we see that there's not this equity in terms of the dip in incidence. And we see that there's been significant decreases in white sexual minority men, for example, but really this minor decreases, but really a plateauing in Black sexual minority men. So we know overall that 1 in 6 sexual minority men in their lifetimes will be diagnosed with HIV. The number is about 1 in 11 for white MSM, and starkingly about 50% or 1 in 2 Black MSM in their lifetimes will acquire HIV. So we know that about when it comes to prevention metrics, as an example, we know that that while 25% of people who are eligible for PrEP were prescribed PrEP in 2020, we see that there's this, again, this large differential, which you'll hear about some of our data. We see that there's, with this 50% benchmark, that white MSM are overrepresented and Black MSM are significantly underrepresented in those who are currently taking PrEP. And so this is just some from a literature review that we were doing, looking at just why we see these low PrEP uptakes in studies. And so the prevalence of PrEP uptake is, of course, going to vary by study, which of course is going to vary by time. And so these are a handful of studies that really represent the field, but we see this consistent low rates of PrEP among Black sexual minority men. One thing that we don't talk enough about, from my perspective, is this the PrEP discontinuation and when people decide to stop taking PrEP. So these are also studies that show that there's a relatively high proportion of Black MSM who take PrEP and then discontinue PrEP. So one study, for example, found that 67% of Black sexual men reported PrEP discontinuation. This Black-white disparity again exists in everything when it comes to the HIV continuum of care. But we also know that Black MSM are less sexual minority men are less likely to be ART adherent, and therefore, not surprisingly, less likely to be virally suppressed. So I'm going to briefly talk about this multi-level perspective, why I think it's important, highlight some key research in the field, snippets of our work, and really foreshadow why we developed N2, why we thought it was important. So this is social ecological model for health, which highlights, of course, there are individual factors that matter for health, but outside of our individual ideas, thoughts, practices, behaviors, there's a context, our friends, our family, communities, et cetera. And these things potentially can influence HIV risk. And I'm going to demonstrate why and how. So first, at the individual level, this depends primarily on biological, cognitive, perceptual, and behavioral factors that are associated with acquisition and transmission risk. This is an early paper led by a former student of mine who's now faculty at Brown, William Godell, and we just essentially looked at barriers to PrEP uptake among sexual minority men in New York City. And we asked various potential things that we thought could be barriers, including side effects. These are just prevalence estimates here, but we see about 30% of our sample reported that they weren't taking PrEP because of side effects. And of course, these were also predictors in a multivariate regression model, and several of these were significant, including believing that PrEP was going to be associated with side effects. People were less likely to therefore take PrEP. So this is some of Lisa Eaton's work, who I've been a significant fan of her work for quite some time. And she shows that, well, there's stigmas associated with PrEP. Various stigmas, one of the stigma of being promiscuous. And the stigma belief has been associated with a lack of interest in PrEP in Black sexual minority men. And her work, and we're collaborating with some of our trans, we have a supplement to do some of this medical mistrust with our trans sample. But we see that medical mistrust is also associated with PrEP use. So, or PrEP, lack of use of PrEP. In particular, she found that not being comfortable talking with your healthcare providers about your sexual behaviors has been associated with less PrEP use in her Black MSM work. So let's talk about this next level. This network level. It includes a wide range of networks, who our friends are, confidants, our family members, of course, our sexual networks, et cetera. I'll just summarize and say, not surprisingly, that networks really matter ubiquitously. This is just a figure from my colleague John Snyder's work, that he shows that people who are bridgers or who are connecting to social networks are more likely to be associated with having HIV infection. And so these are just some network figures from his work demonstrating this also. So we did some work with one of John's earlier cohorts called UConnect, and we wanted to look at some of the network factors that may relate to PrEP. And this outcome, it was an earlier data set, so it was PrEP awareness. And one of the key findings was that having sexual network members in your actual neighborhood was associated with increased PrEP awareness. So now let's talk about the neighborhood level. And this is predominantly what my work is focused on. It determines access to prevention, resources, treatment, various physical facilities that can maintain health. For example, healthy food stores, parks, et cetera. It also can include physical features like physical exposures like air pollution and noise. So in my first study called the NYC Low-Income Housing Neighbors in Health study, I'm outgoing, and participants, came to me and said, Dr. Duncan, this survey really made me think about my neighborhood. I never really thought about my neighborhood before. And some people started to share some experiences that I felt should be documented, especially at the time I was at medical school. So a friend and colleague of mine from college, we made this documentary called Bad Neighbors Affect Your Health, the story of low-income housing residents. And in this particular snippet from the video, this woman who's a low-income housing resident describes her hood as being a place where there's no healthy food options. So she says, in my neighborhood, I actually want to eat healthfully. I get it, Dustin. It's really important. But she really literally couldn't do so because of how her neighborhood was structured. And so a lot of this work that's been summarized on Neighbors in Health, I still think our book is probably the most up-to-date volume. But we highlight that neighborhoods really can have an enduring impact on health. And there's a wide range of conceptual models overall. This is just one that we developed for our book chapter, highlighting how neighborhoods can relate to HIV. Okay. So this is just one of our studies, but a colleague of mine, DeMark Hickson, had this study of over almost 400 sexual minority men in the Deep South. And he had some neighborhood questions and said, okay, DeMark, do you mind if I analyze this and let's see what pops up? So we analyzed this in so many different ways. It was my first foray with his data. And so these results are robust across various modeling approaches. But we found two key things: that reporting neighborhood problems, just self-report in your neighborhood, is associated with drug use before and during sex. And in this paper, given the special issue it was a part of, we didn't report it in this way, but we also found that having these neighborhood problems was actually associated with HIV infectivity as well. So similar to our network work, we did some work with one of John's earlier studies, again, UConnect, and we found various things. Again, this is some early data, but we found that higher neighborhood educational attainment and having greater primary care locations in your neighborhood was associated with greater PrEP awareness among Black sexual minority men. So just to summarize just very briefly, these multi-level factors can impact HIV risk acquisition care behaviors. Individual factors like medical mistrust, network factors like social networks residing in your neighborhood, and neighborhood factors like access to access to primary care facilities. So the thing is that, there's a wide range of limitations in this work overall. While I presented this idea that networks and neighborhoods matter, which I think everyone kind of gets or assumes at some level, the vast majority of the work is still really at the individual level. And I really didn't criticize the literature in this way, but most of the neighbors and networks work has a number of limitations, which I'll highlight through our N2 cohort. So N2 currently has 2 new R01s that's funding it, and I'll talk about that at the end. But these are the original awards, an R01 through NIMH and a CDC U01. So just briefly, our project was looking at how neighborhood and network factors independently and then synergistically may relate to HIV prevention and care. And so as I talk about our study, you'll hear some of the results, and you'll hear a lot of the work from my fellows, so I'm going to call them out specifically. So our sample includes over 600 Black sexual minority men in Chicago, mainly from Chicago, so we have about 412 there. And we have about 209 Black sexual minority men in Jackson, Mississippi, New Orleans, as well as Baton Rouge, Louisiana. We have various data types. We have survey data, we have measured health data, for example, HIV status. We have address and GIS data. We have GPS data, and we have social and sexual network data. I won't talk about the sampling too much. In our forthcoming work, we're doing some comparisons by city. And so I always tell my fellows, like, it's really important that any site differences or geographic differences, we recognize that it could be a geographic difference, but it could also be a sampling difference because we did sample differently. So in Chicago, we really collaborated with John's Chicago Center for HIV Elimination, which is really a research group. So they really understand, how to get participants in and out and comfortable, et cetera. Where in the South, we really collaborated with ASOs. And so their research process was really new to them. And so there was a lot of coaching from us, et cetera. But because of some of the limitations of the research process there, a lot of our engagement with participants was through convenience means, for example, parties, et cetera. So we have various flyers. This is just one from our down south collaborators. We had flyers that also went on Instagram. This is one. This is an event we had before the pandemic. I think it was about October of 2018 in New Orleans from our collaborator Brotherhood Incorporated, where we had various quote unquote swag, t-shirts, et cetera. They would give participants, and essentially just showed up at a club and signed people up to be part of our study. So like most studies, of course, we have survey data, and our survey is both self-administered and interview administered. And we collect this GPS data. I'll highlight why in a moment. But what we do is to give participants a GPS device to wear for about 2 weeks to look at their mobility overall. So the reason why this matters in the first place is idea of spatial misclassification. It really refers to this incorrect measurement of a neighborhood exposure based on the definition used. So the vast majority of work in my world of spatial epidemiology looks at these administrative things like census tracts or zip codes. And the idea here, for example, is that if we say that people in census tract, we're going to look at exposure to this park, we would say that people in census tract B have access to this exposure parks. When in fact, when we look at the geographic distribution, we see the exact opposite exists. We see that people in census tract A actually have more access to this park. And this would be one example of spatial misclassification. So this is a little old now, but this was a paper I wrote as a fellow. And what I did is I was just curious about different neighborhood definitions, and not just visually, but also empirically. This is just a visual that shows many ways we could define a neighborhood for a youth. Data set that I worked with for my dissertation and postdoc. But also what I did is I demonstrated, or I got those effect estimates, and I computed whether they were significantly different or not. And so not surprisingly, they were. The other issue with this idea of looking at one neighborhood type or administrative types of neighborhoods is that we only generally look at the residential neighborhood. When you can imagine that, my exposure to San Francisco in these couple of days is going to influence something, my happiness, my, my eating behaviors, et cetera. So it is a major limitation. And we'll refer to this as the residential trap. So it refers to this exclusive idea of focusing only on the residential environment. But of course, individuals spend time in different places in different contexts. And some of my work is in the CVD space, less so, but with a close colleague of mine from Paris, Basile Shea. But he conducted a review that shows that over 95% of studies, in the neighborhoods and cardiometabolic field focus exclusively on the residential trap. So this idea of spatial polygamy or spatially mobility was really argued by this early geographer, now deceased, John Odland from Indiana University Department of Geography. And my colleague from Penn State, Stephen Matthews, has really been conceptually leading this idea of spatial polygamy, that different types of places can matter. Of course, where we live, but also where we work and where we socialize, and as well as places where we do errands and we shop. So a colleague of mine from New York, when I first faculty appointment, had this data set of sexual minority men, and he had some different type of neighborhood exposures. And so we knew where participants lived, we knew where they had sex, and we knew where they socialized. And so this very early analysis, I was just curious whether they were the same or not. It was a really simple question. And the main result is that we found that 75% of participants, 75% report not having the same types of concordance. So their residential, sex, and socializing neighborhoods were different. So now I'm going to highlight why GPS kind of studies matter, and the work we do. To date, we've been giving participants a dedicated GPS device where we can look at their mobility patterns overall. In the kind of first foray in this work, we wanted to do some proof of concept. So kind of in the literature, you'll see that we've demonstrated that it's feasible. But what it also demonstrates is that beyond the feasibility aspect, that people are mobile outside their neighborhoods. And you see here, we intentionally, I'm not sure those of you who are online can see it, but we intentionally obscured participant patterns within their census tract to make sure that no one could be identified. And it's a random participant in the data set, but still. And we've also done some of this work with Black sexual minority in the South. And again, it highlights, for example, in New Orleans, that this participant does hang out in their neighborhood, which you don't see here because I've obscured it, but around their neighborhood. But we also see that they hang out significantly outside their neighborhood. The darker orange represents more time spent in that place. And just for those of you who may know New Orleans, the darker spot that's north is the French Quarter. So we followed this work up with GPS data. And so this is a paper that I wrote that came out in Spatial and Spatial Jumper Epidemiology, where we found that participants spend significant time outside of their home their home neighborhoods, including about 33% outside of their home neighborhoods. So there's many types of ways we can study networks, egocentric and socio network methods. Typically, we give participants a network questionnaire and we ask them about their X, number of closest social network members, sexual network members, et cetera. What we do in N2 part 1 is we ask about their 5 closest confidants, and then their 5 most recent sexual partners. And then we follow up with this kind of really extensive battery of aspects about each network member, their age, their gender, their race, ethnicity, their HIV status, if they know, whether they're in PrEP, whether they're ART, et cetera, et cetera, et cetera. So the vast majority of studies really focus, network studies focus on this egocentric approach. But through a matching, we're able to make this kind of structural network. So we're able to connect people within existing cohorts. So what we've done in N2, and I'm not going to present some of that work. One of my fellows is kind of cleaning some of that up. But what we did is we downloaded each participant's Facebook and cell phone data. And so what we did is we matched participants in our network, in our cohort who knew each other. Not surprisingly, there are various types of outcomes that we examine, HIV and not in the cohort. So COVID happened, and I'm going to talk about a little bit what it did. But of course, COVID, maybe I shouldn't have put the slide up, but it just has really impacted everything. And I'll say our current cohort is going so well because what we did is we immediately stopped it and we just restarted the cohort. And so everything is virtual. And so I think that's why our retention rate is so high there. But COVID still, of course, remains a public health issue. Over 1 million people have 100 million people in the US have been infected with COVID, and 1.1 have died of COVID, unfortunately. So one of the things we did with COVID, of course, is first stop our studies, and we just met a lot. I also proposed a book to Oxford during this time, and just to call out that it's finally coming out. So it should be out in a couple months, where we highlight that various social factors, of course, neighborhood network factors, but other things, your religion, your race, SES, Maria Gleimer wrote this amazing chapter on socioeconomic status, really impact one's COVID outcomes. So in addition to stopping the cohort, we would just meet via Zoom, and we said, "Wait, hold on. If we're meeting via Zoom, we could actually turn this into a study." And I'm sure a lot of our colleagues, and you see that in the book, have done the same. So from April to June, what we did is we collected data from 226 participants. We asked things about PrEP, ART, IPV, sexual behaviors, etc. So these are some of the overall characteristics of the sample. Our sample is really socioeconomically deprived. About 50% of our sample are unemployed. About 64% make less than $20,000 a year. And I think, I can't see the numbers here, but I just know it's about 1/3 of our sample report being unstably housed. Here we see that about 60% report being not living with HIV. We see that about 40% report never having taken PrEP. And I forgot to call out that about 80% report inconsistent condom use. So now I'm going to highlight some of our key findings from this multi-level perspective, starting with the individual level. So this slide I'm actually going to present next Thursday when I teach my course. But we know that there's 3 different domains or ways we can measure sexual orientation: sexual identity, sexual behavior, and sexual attraction. And there's been some work in the field, which I think is great, which highlights that there's not this perfect overlap, which of course makes sense. But I think as epidemiologists, it's really important for us to recognize that in terms of when we're sampling participants and what we're gleaning from our data. So what we wanted to do in our study is we wanted to look at whether the sexual orientation construct, in particular sexual identity and sexual behavior, which we had in Chicago, how that could be related to HIV risk. And particularly wanted to look at, or HIV prevention in this case, what we really wanted to look at was PrEP use. We found that identifying as bisexual, reporting sex with men and women in the past 6 months, and the combination of the two was associated with lower oral PrEP uptake. We also found that bisexual identifying men who report having sex with men and women were more likely to discontinue PrEP than gay identified men who had sex with men only. And this is just a figure that shows that. And I just really think here, it really highlights the importance of disaggregating groups. So another one of my fellows, a Red Driver, wanted to do this with our southern aspect of the cohort. And in the southern cohort, we actually had the attraction items. And first I asked him to make these figures because I wanted to visually see how much overlap there was. And so this is the overlap in identity, attraction, and behavior among gay identified Black men. And we see that only about 23% there's this overlap for all 3. And this is the overlap. This is the overlap for identity, attraction, and behavior for bisexual men. And we see that overlap is only about 17%. This relates, of course, to risk. We see here that men who report having sex with men and women were were more likely to report a condom sex in the past 6 months. Men who identified as bisexual or straight or something else were more likely to have bought sex in the past 6 months. And finally, here we found that people who were attracted to both men and women and who report bisexual identity were more likely to be tested for HIV. So I started to do this work in sleep early in my faculty position. And I attended this conference, and this leading sleep epidemiologist really highlighted that sleep is so important for health. And she talked about, I remember this talk where she talked about sleep and drug use and relating sleep to sleep is this significant risk factor. And I remember being in Ken Mayer's office, who's a colleague at Venture, and I said, Ken, do you think sleep can be associated with HIV? And he said, I don't know, Dustin. Go on the board and draw a DAG. And I literally started to draw this DAG. And in tandem, one of my students had a survey on Grindr that we were going in the field with soon. So thankfully, I was able to slip in some 2 sleep items. And some of this early work, we found, we looked at sleep in sexual minority men, and other colleagues have kind of followed up with our data. But sleep is just important for health overall, but it has been associated with HIV risk. So this is one of our early studies, for example, where we found that a typical night's sleep of less than 7 hours was associated with increases in condomless receptive anal sex. This is a paper that we have in review for a really long time now, but we also see that sleep is associated, or poor sleep and sleep problems are associated with interest in long-lasting injectable PrEP. And when it comes to Black sexual minority men, some colleagues have also done this work specifically with Black sexual minority men. So this is some work that shows, for example, that short sleep duration is associated with decreased condom use. And sleep problems are associated with STI diagnosis in the past year. So this idea of intersectionality has come up in our work, of course. And this is a study by a colleague of mine, Billy Carreras from Columbia, who did use some national data that found that Black gay men in particular had the highest odds of short sleep compared to every group, not just white gay men, but also compared to their white heterosexual counterparts overall, highlighting that this is a key population. So we proposed this study, and it came out now, where we looked at whether sleep problems or sleep disturbance in N2 can be associated with PrEP. And what we found is that that reporting a sleep disturbance you are more likely to essentially miss PrEP. And just wanted to highlight that, a lot of the sleep work that I've been doing has been summarized in a book that came out in 2018 with Achiro and Susan Redline. So now I'm going to talk about some of our network work. So one of the first N2 papers, we wanted to look at neighborhood and network factors as it may relate to PrEP and to viral suppression. And what we found and we did a analysis stratified by HIV status, and we found that participants who were vulnerable to PrEP, so participants who were not living with HIV, we found that having a parental figure within an individual's confidant was significantly associated with greater likelihood of PrEP use. We also found that participants who were living with HIV, having confidant network members aware of one's HIV status was associated with viral suppression. So this is a paper that's in review by a fellow of mine, Chohi Schrader. We wanted to look at whether social network associations could be associated with HIV prevention conversations, among Black sexual minority men in our cohort. And what she did is she first just visualized the egocentric confidant networks. And so I'm not really the best person to narrate this, but I just thought it was a really cool slide where we're able to actually look at the participants, aspects of the participants in terms of whether their confidant members were family, friends, et cetera. More substantively, there are many key findings from this, but one, we found that having family members in your as part of your confidant networks, you are more likely to have HIV and STI prevention conversations with them. So now I'm going to talk about our neighborhood work. We have an N2 GPS working group, and we're finally going through that. So I'm not going to present some of our GPS findings today. Instead, I'll present some of our survey work. And in the future section, I'll talk about the next steps and the neighborhood stuff. So I've been interested in police violence for a while. I'm a consultant on a colleague's grant from NYU, Maria Khan. And through HPTN, I think 061, we've a couple papers coming out that we've highlighted that neighborhood policing matters overall for Black sexual men. And we look at it in many ways, including intersectionally, so based on their race, based on their sexual identity, as well as based on both. And these are, of course, perceptions. So that's the frame for this. So this is a cartoon figure that I saw, kind of, I think, when George Floyd was happening, which I'm going to talk about in a second. And this is what I perceive to be a white police officer who asked us, what I perceive to be a young Black boy, what do you want to be when you grow up? And the boy responds and says, alive. So there's been a lot of work that shows that Black boys and men who feel less safe in white neighborhoods, and actually that police violence is a major public health problem for Black cisgender men. So yeah, we hear it in the news, but there's data to back it up. And these are just some increasing media attention given to police violence with the focus on Black men. So this is a quote from Jacob Blake's sister, who was a Black man who experienced police violence. I'm not sad, I'm not sorry, I'm angry, and I'm tired. I haven't cried one time. I stopped crying years ago. I am numb. I've been watching people kill police. I've been watching police kill people who look like me for years. And these are the names of mainly Black men who, and pictures of Black men who have unfortunately experienced police violence. And so George Floyd happened, and it got a lot of attention in terms of being in the New Yorker, murals, et cetera. So I will just briefly talk about that. Because as it was happening, we were actively starting to do some of this police work. So he was killed by police in May of 2020. Initially, and importantly, there was conflicting autopsy reports. But later, eventually, it was ruled that it was a homicide, and the police were eventually charged. There were protests, and people wrote signs like, I can't breathe, say its name. And the protests, I think, definitely contribute to some intention, but also it highlighted that this is something that's not new, and there are so many names, including recent names. So this is a paper that we should have in review soon, but we look at whether neighborhood policing practices could be associated with HIV status neutral care among our sample, including both the Chicago or the Midwest site, as well as the Deep South sites. I'll present some of the results overall right now, but we do see some site differences. So some of this work is supported or through the literature. So for example, a colleague of mine, Devin English, has done some work looking at policing factors and PrEP. And so in our study, we found that we looked at policing practices two ways: police neglect, so police don't come to your neighborhood, and excessive police presence in your neighborhood. We found that about 32% of participants report police neglect, and about 38% report excessive police reports, where it's a big problem. We also asked about it being a moderate problem. More substantively, we found that neighborhood policing neglect was associated with lower prevalence of HIV testing in the past 12 months, lower odds of ART use. We found that excessive police force, on the other hand, was associated with lower odds of PrEP adherence, lower odds of ART use among those who are living with HIV, and a lower odds of HIV status neutral care. So now I'll talk about some of our next work. I'm currently planning an R01 where we have colleagues of mine from Columbia have a specific address data for each crime, including policing factors in Chicago. And we know, they really know very nuanced aspects. For example, the police race, ethnicity, police gender, many things. And so we have a draft Ames page where we want to look at its objective policing practices and tie it to our cohort. So I'm currently planning that. As I mentioned, N2 is now in the field again. We started our part 2 of N2, where we did this relaunch. We're calling it N2P2 in September. I didn't open their progress report, but I think it was as of last week, we had about 100 participants. So we're recruiting 600 in this new wave. In this new wave, we're focusing on cannabis use specifically, and we can talk about why, and sleep. This is the conceptual model from the grant about sleep. This was in August of 2022, where we had this kind of event where we, had this kind of community event where we highlighted our new study, and we talked about some of our study results. We again have many events highlighting our study and give flyers out throughout Chicago. Other literature in the field of neighborhood health is we generally get these overall estimates. And so what that means is we lack this we almost assume that there's this lack of within-person variation, but that's not necessarily true, right? So within one's day, we may have variations in our happiness or variations in anything, quite frankly. And this method of EMA or ecological momentary assessment is one method that we could assess this day-to-day variation. So in this new wave of N2, we're getting EMA data on many factors: policing, substance use, et cetera. And these are just some figures as we were kind of pilot testing that protocol. The other issue is that there's in the field is that there's tend to be this lack of spatial temporal link between studies. So we assume that we know the where and the when, or we assume that they're paired together when that may not necessarily be the case. And there's this method called geographically explicit EMA, which can help us understand both. And so while we don't have any grants to look at that yet, we and others have done some feasibility work, including with Section Running Men, that demonstrate that that it's somewhat feasible. Although most studies to date have used really small samples, so under 50 participants. It can be used as a observational tool, but also an intervention tool. When it's used as an intervention tool, we refer to it as geofencing. And so I currently have an R34 in review with a Hopkins colleague, where we propose to do a crossover design to determine the acceptability and feasibility of a geofencing intervention for HIV status neutral care for Black sexual minority men. And just briefly, I'll just summarize this in my own words. Essentially, we will define participants or places as risky places and other places. And when participants are around places, for example, risky places, we can send them a ping. For example, manage your stress in this way, and based on our hypothesis, and DAG, we'll see how it plays out. And this is just kind of our overall conceptual model of how geofencing may relate to sexual health in our sample. And just in closing, because I think we're at time, I've been wanting to do global work for a while. So we know HIV disparities overall, and I really loved this review for a while because it highlights that HIV remains a public health issue on Black MSM globally. So we're doing the work here, and thankfully we have funds to do that. We're a grant in review to do continue some of the Deep South work, but we're finally doing the global work. So I'll just highlight that briefly. But we want to span to Europe, and we want to span to sub-Saharan Africa. Right before the pandemic, a colleague of mine, Rusi Jaspal from the UK, reached out to me about doing some London-based work, and we're talking about and planning some kind of small studies. But I have this study that I'm submitting in May, where we're planning this kind of N2 Nairobi study. I was supposed to go last week. There was a visa issue, and now I'm going in mid-March. But essentially, we want to use some of the work that we've learned about neighbors and networks, in particular social capital within neighbors and networks, as a tool to potentially increase HIV prevention and care. This is our proposed team that we're solidifying and developing. And essentially, we want to adapt to existing effective interventions for HIV prevention and care. And so this is an intervention called Kangala. It's been effective at increasing ART adherence for people living with HIV in Kenya. And this is one of John Snyder's interventions, PrEP Chicago, which has been associated with increases in PrEP use in the sample. Thank my funders, and I want to thank my colleagues, and particularly two of my fellows, Shohi Strader and Red Driver, for rerunning some analysis for today. Thank you, everybody. Oh, thank my team, sorry. Monica.
That was just amazing. The breadth of your work
Thank you.
is incredible. And I can't believe you wrote a book on the pandemic. One question I had is about the neighborhood question, which is like such a unique topic because it is spans so much, right? Like there's poverty, there's policing. And then one question I have is about environmental factors in a neighborhood. And we've had a lot of discussion in San Francisco about our traditionally Black neighborhood, Black Bayview, Hunters Point, and kind of where it's built and the industry around there and the factories and like the actual environmental climate aspect of neighborhoods.
Yeah, in Chicago, one of the things part of the talk was also cautionary in a way, because how we collect or how we sample people, and I'm thinking through some commentaries and other things like that, of course, influence our findings, but we don't really talk about it enough. So I just submitted our final RPPR for the first R1, and I highlight that, some of our neighborhood findings self-report weren't significant. This was, but many of them weren't. For example, neighborhood poverty. Why? Well, and actually in N2 Chicago, we sampled basically from Black neighborhoods. So my assumption is that because of our sampling frame, we see this kind of lack of variability. We only see associates in there. But we knew that I highlighted our book, Neighbors in Health, because what we did is we really spent real time identifying the leaders, real time thinking through what the topics and issues were, and real time really demonstrating that neighborhoods in nuanced ways can have impacts. We know that segregation exists. Many colleagues have demonstrated that. A mentoring colleague of mine, David Williams, of course, but also like younger colleagues in the field, like Michael Kramer from Emory. We've seen this in a wide range of studies. Some of my early work demonstrates that. So one of my first studies as a fellow, we looked at racial residential segregation, and as it can be associated with different neighborhood amenities. And one key finding, I think, is published in the journal Urban Health, maybe 2013 or so. We found that Black neighborhoods had less parks. Not surprising, parks is an amenity, but it's also associated with health, including physical activity. I think overall, we need to do more in the space of identifying neighborhood aspects that are salient, but also when it comes from an HIV standpoint. But I think at this point, I'm a little, I wouldn't say frustrated, but maybe by the observational work, and I really want to dip my toe into kind of the intervention work. And, like a lot of my psychologist friends, I'm equally frustrated. These interventions aren't scalable and, implementation science, et cetera. But I feel like I want to try to implement or use the observational work that we've learned to implement or try to see if these contextually based interventions are effective. Because I feel like many of the interventions to date don't really fully account for one's context. And I'm really thinking about it. So, we can write an R1 and potentially get it and do something in Kenya, and that's great. But like, I'm really going there and really spending real time there. So like we can develop something that could be meaningful and hopefully sustainable.
Yeah, that was really terrific. So I'm interested in the GPS devices that you those studies, and I imagine you must have needed to overcome some barriers in terms of medical mistrust that that the data would not be misused. And what did you learn about sort of overcoming those challenges, communicating to participants to reassure them that that things wouldn't be misused?
Yeah, that's a great question. So that came up in all of our studies, and we spent real time building the foundation by getting real pilot data. I wrote actual grants just to collect data on the feasibility to demonstrate how, and I didn't talk about the nuance. I just kept saying it's overall feasible. But of course, that there's a lot of nuance there. The way we describe our protocol to participants is we're not interested in, it's not actually real time. We don't actually know where participants are in real time. We only know when we get our data back in the way that we collect it. There was a lot of intentionality there because I wanted participants to feel safe and comfortable. The other thing we did is that we intentionally didn't sample from participants' smartphone devices because of those issues. But what we say in our protocols overall is that we're not interested in particular locations that you're at. We're interested in the general neighborhoods. So we showed them that we're going to look at the overall aspects, not the specific location, but the general spaces around it. And we highlight why and how it matters. Surprisingly, beyond it being kind of annoying to participants, people have generally carried it. We see site difference, so we could talk about that, but in the same thing with our current study with trans women, people have generally worn the device. Sometimes we've had to, implement the protocol a couple of times. People have lost it, et cetera. But those issues haven't been there. I would say I have a paper in the MSM, the Sexual Minority Men Space, published in PLOS One. It's a feasibility paper. I think that's probably the better of the series, and that really highlights all the issues about. I don't know if we look at medical mistrust that way, but would you want to do it again in another research study and those kind of questions, and that potentially could be helpful.
Really great talk. I'd like to learn a little bit more about some of your sleep studies and
Sure.
where those are going. I'm actually visiting. I'm from Chicago, and we've been doing a lot of the studies in the WISE cohort at Cook County and
Awesome.
On the west side, and a lot of actigraphy type of studies. And interestingly enough, we have a grant, and Peter would be interesting looking at the role of sleep in kynurenine and tryptophan pathways as well in one of our R01s. But I'm wondering where you're taking this work further and understanding sort of the link between the outcomes and community research and maybe back to more of the basic science and other
Yeah.
studies? Thanks.
So I would say two ways: sleep as exposure and sleep as an outcome. Sleep as exposure, our early work, I wanted to demonstrate that sleep mattered. So I looked at, well, our early work, I kind of highlight to colleagues like, hey, I think sleep matters in this population. And I would talk about it. And I remember colleagues would say, well, I don't really believe it. And our first paper that we published there in Sleep Health, proud to say it was the first paper that looked at sleep health in any sexual minority men sample. One of the reviewers said, like, essentially, this doesn't matter. And so like I had to really highlight, well, this actually does matter. So I wanted to just demonstrate that it mattered in the first place. And then we looked at sleep as an outcome. So for example, we have papers where we've looked at neighborhoods and sleep, and not surprisingly, we found that neighborhood safety is associated with issues with sleep. But the R1 that we have, I've tried to get R1s funded for a while in sleep space in different ways, in different capacities. This one is an HIV link. So we're looking at how sleep relates to ART adherence more specifically in our sample.
I mean, another important corollary is circadian rhythm on top of that. And that's a lot of what we've been looking at and asking about circadians and sleep. So have you dug a little deeper into that aspect as well?
So we've looked at a wider range of sleep health attributes overall. So in preparation for the R1, we used one of our waves of data collection as essentially getting pilot data. So we looked at a wide range of things beyond beyond traditional sleep problems, sleep issues like restless leg syndrome. I kind of quite frankly don't remember the wide range or the complete list. But we have looked at that data in a kind of in a preliminary fashion, and we're in the next round of data collection for N2, wave 7, wave 2 of the new R1 series. We are developing our sleep stuff, actigraphy, of course, but we are looking at the wide range. What I'm trying to do with our team is I want to basically look at the distribution. We had something like 100 sleep items that we asked, and so I want to look at the distribution to look at what we can and should include in our next round. But the substantive work, I would say, is looking at sleep as it relates to ART adherence. But I'm planning to look at sleep also as an outcome, maybe as a covariate. But Yeah.
So I want to be mindful of the time,
Yes.
and I want to thank you very much, Dr. Duncan, for this fantastic
Thank
talk.
you very
And
much, Mallory.
I would encourage people to reach out and
Of course,
with questions or comments or
Thank you.
invitations to collaborate, because clearly you have plenty of time on your hands. And so, lots of room to fill. So thank you very much.
Thank you, Mallory.